clinical syndromes such as nephrotic syndrome and nephritic syndrome, their definitions and their common causes. And then we will also discuss different types of glomerulonephritis such as minimal change disease, focal and segmental glomerulosclerosis, membranous glomerulonephritis, membranoproliferative glomerulonephritis, and diffuse proliferative glomerulonephritis. Okay, so now what is the definition of nephrotic syndrome? Nephrotic syndrome is basically defined as proteinuria more than 3.5 grams in 24 hours with hyperproteinemia, edema, and hyperlipidemia. This can be classified as primary idiopathic nephrotic syndrome or secondary nephrotic syndrome. Now, primary or idiopathic comprises the majority of cases, about 90% of them. Secondary comprises about 10% only. In very rare cases, the patients can present as congenital nephrotic syndrome when the presentation is usually in the first 3 months of life and the cause is congenital. So there are various causes of primary nephrotic syndrome. Out of these, the most commonest are the first four, that is minimal change disease, focal and segmental glomerulosclerosis, membranous glomerulonephritis, and membranoproliferative glomerulonephritis. All these four conditions we will be discussing in today's lecture. Causes of secondary nephrotic syndrome are numerous. These include infection, which include post-infectional glomerulonephritis, the causes being infective endocarditis, hepatitis B infection, shunt nephritis, and malaria. Then it can be caused by various connective tissue disorders. These include inoxazoline purpura, SLE, polyarthritis nodosa. There can be certain familial conditions such as Alport syndrome leading to secondary nephrotic syndrome. Neoplasms such as Hodgkin's disease and leukemia can also present as nephrotic syndrome. Various medications, commonest of which is non-steroidal anti-inflammatory drugs, are also the cause of nephrotic syndrome. Other medications include anticonvulsants, penicillamine, serum sickness, food allergens, and insect bites. Last but not the least, amyloidosis is also a cause for nephrotic syndrome. It is one of the very common causes of nephrotic syndrome in our country. Now, what is the pathophysiology? How does nephrotic syndrome develop? The nephrotic syndrome is primarily caused because of derangement in the capillary walls of the glomeruli, and this derangement is either structural in appearance or it is physicochemical in appearance. So whether it is structural or physicochemical, the basic condition that it produces is a damage to the glomerular basement membrane and the photocytes, leading to an increase in the permeability of the basement membrane to various plasma proteins. So with the increase in the permeability of the plasma proteins, then as a result of this, a lot of proteins they escape from the plasma into the glomerular filtrate, producing the condition of proteinuria. And when this proteinuria is of long standing or is extremely heavy, it results in decrease in serum albumin level, which is called as hypoalbuminemia, and a drop in the plasma colloidal osmotic. Then there is a decrease in this drop in the plasma colloidal osmotic pressure will lead to a decrease in the intravascular volume and the renal blood flow. It stimulates the juxtaglomerular apparatus to produce renin. This renin in turn acts upon the angiotensin-aldosterone axis, leading to retention of salt and water by the kidney, which eventually leads to the third symptom, that is edema. Now, this hypoalbuminemia, in addition, it also stimulates the liver to produce or synthesize massive amounts of lipoproteins, which presents as the hyperlipidemia. This excess of lipoproteins can also be caused because of a loss of the inhibitor of its synthesis, which is passed out of the urine along with the various proteins that are leaking out from the glomerular basement membrane. The excess of the lipids eventually can also lead to loss through the glomerular basement membrane into the urine, a condition which is called as lipidemia. This is a diagrammatic presentation of your entire of this development of nephrotic syndrome. So this includes, for example, there is glomerular damage leading to increase in permeability of the glomerular capillaries to proteins. This results in proteinuria, which is to the extent of more than 3.5 grams in 24 hours. This reduces hyperalbuminemia, so the serum albumin level falls to below 3 grams per 100 ml. This leads to a fall in plasma oncotic pressure. So therefore, this forces the fluid to escape out from the blood compartment into the tissues, leading to edema. In addition to this, the fall in the plasma oncotic pressure will lead to a decrease in plasma volume, decrease in GFR, increase in aldosterone secretion, and eventually fluid retention, which again reduces the edema. The hyperproteinemia in turn leads to compensatory synthesis of proteins, including lipoproteins by the liver, which leads to hyperlipidemia. So this is how all the different components of nephrotic syndrome they develop. Now the first disease which causes nephrotic syndrome, the commonest of disease is minimal change disease. The minimal change disease accounts for about 80% of all cases of idiopathic nephrotic syndrome in children, where it is commonly seen in the 3 to 4 years age. In children, there is a male predominance to the tune of 2.5 to 1. A similar male predominance is also seen in minimal change disease when it develops in adults. The cause is idiopathic in nature. However, it is believed that there is a T cell derived factor which causes podocyte damage and effacement of food processes. This T cell derived factor production may be associated with infectious diseases, recent immunization, or ingestion of heavy metals. In adults, the T cell derived factor can be related to the use of non-steroidal anti-inflammatory drugs. Now, what are the common microscopic features of minimal change disease? As I already mentioned in the last time's lecture, that we will be discussing all kidney biopsies and its key headings: light microscopy, immunofluorescence, and electron microscopy. In light microscopy, in minimal change disease, the glomeruli look completely unremarkable, except that the proximal convoluted tubules, they show large amounts of proteins and lipids. Immunofluorescence also is negative for all immunoglobulins and complements, and however, the change that is primarily seen is on electron microscope. So this is what the glomerulus of minimal change disease looks like under BSD. Absolutely unremarkable. The mesangium, in nowhere is it showing an increase in rarity. Maybe this one small focus over here, but otherwise remarkable. The tubules show presence of these protein reabsorption granules, which look like these small pink droplets. On immunofluorescence, all the immunoglobulins and complements are negative. And last time I mentioned to you that when we are examining the kidney biopsy by immunofluorescence, we put up different immunoglobulins: IgG, IgA, IgM, complements C3 and C1q, and light chains kappa and lambda. Right? I explained to you the process of how we put up this and the rest of immunofluorescence. So all these markers are commonly seen, all these markers are commonly used in all kidney biopsies. In case of minimal change disease, none of these will be negative. So now on the EM, what happens is that this is a normal structure of the glomerular capillary wall. In a normal kidney biopsy, I showed this figure to you last time. This is the mesangium. This is the capillary tube, and on the surface of the capillary tube, you can see the processes of the food processes of the podocytes, which are arranged peripheral to the long axis of the glomerular vessel. But in this case, what happens is you can see there are no such perpendicular food processes. There is complete flattening of the food process, a phenomenon which we call as diffuse effacement of food process. So this diffuse effacement of food processes, this is the classical change of minimal change disease, and as you can understand, that we will require electron microscopy to confirm the diagnosis of minimal change. Now, what is the clinical cause of patients with MCD? It's quite good actually. In most of these patients, the renal function is preserved despite the high levels of proteinuria. That is, the serum creatinine level will be within normal range. However, there is marked protein loss in the urine, and this protein loss is usually confined to the smaller plasma proteins, chiefly albumin, a phenomenon which is referred to as selective proteinuria. Most of these patients recover with suitable doses of steroids, but more than 90% of them, only in 10% of cases, these patients start having recurring episodes of nephrotic syndrome. Whenever we withdraw the steroids, they eventually become steroid resistant and go on to develop chronic kidney disease requiring renal transplant. So this was the end of the first disease. Now we come on to description of focal and segmental glomerulus. As we discussed in last time's lecture also, what is focal and segmental glomerulosclerosis? Focal basically means that only some of the glomeruli of the kidney are involved, and not all of them are involved. And also, in addition to that, only a part of the glomerular duct is involved. That is, a segmental involvement is present. Not the entire duct is not involved. For example, this is the H&E stained glomerulus in a case of focal and segmental glomerulosclerosis. That this part is your sclerosis, right, or the scar formation. Whereas this part of the glomerular duct looks unremarkable. Now, in addition to this, the scar is attached to the Bowman's capsule. Here also, if you trace the Bowman's capsule in the black and white diagram, then the scar tissue is attached to the Bowman's capsule, which is referred to as synecdoche formation. So these are the features of focal and segmental glomerulosclerosis. This focal and segmental glomerulosclerosis, or FSGS, that is more commonly called, leads to development of nephrotic syndrome in about 10 to 15% of cases of nephrotic syndrome in children, and is the cause of nephrotic syndrome in 20 to 30% in adults. The FSGS is the predominant cause of idiopathic nephrotic syndrome in adults. In children, when it occurs, usually it involves them when they are less than 5 years of age. In adults, the most common age of presentation is the 3rd and the 4th. So, like for other nephrotic syndromes, the causes of FSGS can be primary and secondary. Now, primary or idiopathic, as is the classical description. Secondary, you have a lot of causes, such as now, for example, any inflammatory disorder of the kidney, it eventually heals by scar formation when it is called a secondary FSGS. The commonest cause of this is IgA nephropathy. Then other tubulointerstitial renal disorders, such as chronic reflux, pyelonephritis, and interstitial nephritis, can also lead to development of secondary FSGS. Then unilateral renal agenesis, HIV infection, heroin addiction, morbid obesity, sickle cell disease, congenital heart disease, glycogen storage disease, and hypertensive nephropathy. All of these can be the cause of secondary FSGS. So, what is the pathogenesis of FSGS? Again, the initiating event of primary FSGS is injury to the podocytes, leading to the complete effacement and increase in permeability of the glomerular vascular membrane. Now, the cause of this is unknown. However, it is believed that this is because of various secretory factors produced by lymphocytes. One important point that you must be aware of, that the entire disease process of MCD to FSGS is a part of a continuum. And many patients, they present first with MCD, and eventually, as the disease progresses, they want to develop focal and segmental glomerulosclerosis. On morphology, what will you see? On light microscopy, you will see the classical lesions of focal and segmental glomerulosclerosis, which I have already described. On immunofluorescence, there is non-specific trapping of IgM and C3 deposits in the sclerotic areas. On EM, again, this is the podocytopathy, that is a disease involving the podocytes, and it shows fusion and effacement of purpose. So, this is what the case of FSGS will look like under the light microscope. So, this is the H&E stain, which is showing a classical scar over here. This part of the glomerular duct is undermarked. This is the PS stain, which shows the classical scar, which is strongly PS positive. It is also positive on silver methylamine stain. and or as well as in basal stratiformity. Now, this is high-power view of a glomerulus showing focal and segmental glomerular sclerosis, where here you have the scar formation, and in this scar, very often you have deposition of hyaline globules as well. On immunofluorescence, as I said, there is non-significant specific trapping of IgM in the scarred area for C3, and similarly also for IgM. On EM, this is your glomerular capillary wall. Here you have the RBCs in the lumen of the glomerular capillary, and on the outer surface you can see that there is diffuse effacement of fibers. This will confirm the diagnosis of focal and segmental glomerular sclerosis if you put together the light microscopy, immunofluorescence, and the EM. Now, the problem with FSGS is that in MCD, for example, if you treat the patient with steroid, the child does very well. But in FSGS, the prognosis is not so. Now, the glomuli which is showing you segmental sclerosis, eventually they will go on to progress in disease, and they will go on to develop global sclerosis. Now, when this happens, when the glomuli are globally sclerosed, as we discussed last time, that the blood supply coming out of this glomuli is also destroyed, and therefore the associated tubule will also undergo atrophy. The remaining glomuli, they have to take on the function of these sclerosed glomuli, so they become enlarged in size. They show compensatory hypertrophy, which in turn causes increase in intravascular pressure and therefore development of further scar formation. So therefore, this disease is inexorable and it keeps on gradually progressing with passage of time. As more and more glomuli get sclerosed, their associated tubules also get atrophied, and there is deposition of collagen in the interstitium. So thus, this disease process keeps on going until eventually the patient develops end-stage renal disease in a period of about 10 to 20 years in at least 50% of the cases. At this time, the only treatment option that is left for the nephrologist is for the child to undergo renal transplant. This is scene of Holi in Mathura. Just a break, and then we go on to the third disease. The third disease is membranous nephropathy, which we need to cover today. Now, as the term membranous glomerulonephritis suggests, that here the basement membranes, these are markedly thick. This is a spotter diagnosis on low power on the kidney biopsy. You should be able to make the diagnosis. Membranous glomerulonephritis is the commonest cause of nephrotic syndrome in adults and usually occurs between 30 to 50 years of age. This is characterized by accumulation of electron-dense immunoglobulin containing deposits along the subepithelial side of the basement. So this leads to a diffuse thickening of the capillary wall and also formation of spikes, which can be identified on silvermethylene stain. So both these factors, that is diffuse thickening of the capillary wall and formation of spikes, these are the microscopic hallmark of membranous glomerulonephritis. So again, like for the minimal change disease and focal and segmental glomerular sclerosis, majority of cases of membranous glomerulonephritis is idiopathic in nature, comprising about 85%. 15% of these are secondary to various other associated systemic conditions, which including neoplasms of lung, colon, or malignant melanoma, autoimmune diseases such as SLE and thyroiditis, infections such as hepatitis B, syphilis, and malaria, and drugs such as penicillin and now in the recent years, a lot of progress has occurred. Work has been done by scientists on membranous glomerulonephritis, and they have discovered that the primary membranous glomerulonephritis has been morphed till date. This is actually an autoimmune disease where an antibody is formed against the self-antigen. What is the self-antigen? This is a endogenous podocyte antigen, which is called as phospholipase A2 receptor. So the autoantibodies are formed against this phospholipase A2 receptor. They then come into circulation, where they can be measured in the serum by ELISA. They then get deposited in the glomeruli, where they react with the antigen which is present in the podocytes to form an antigen-antibody reaction, And here these antibodies, they can be demonstrated by a special IHC marker by which you can confirm the diagnosis of membranous, primary membranous glomerulonephritis. So how does the development occur? So once these antibodies are formed against the PA2 receptor, they get attached to the antigens in the glomerular membrane. So here they cause capillary damage by activating the complement pathway. This leads to formation of C5b to C9, that is the membrane attack complex, which damages the podocytes and the mesangial cells. This causes the damage to the filter mechanism of the glomerular basement membrane and leads to increased permeability to proteins, leading to heavy protein. Now, on morphology, what will we see? As we discussed already, there are two hallmarks on light microscopy: diffuse thickening of the glomerular basement membrane with formation of spikes, which are demonstrated on silver membranes. This is what the glomerulus will look like under light microscopy. You can see that this is pretty large glomerulus. The basement membranes on PA stain, they look very thick. They don't look thin as we saw in the normal glomerulus, right? In addition, when you do the silver methylene stain, you can see there are fine spikes all on the outer surface of the basement membrane. Here also you can see a fine fluffy projection. These are the spikes. This is a high-power view of the Jones silver methylene stain, where you can see these numerous spikes present on the outer surface of the basement. So this confirms a diagnosis of membranous glomerulonephritis. But what is the cause? This is determined only by immunofluorescence. In primary membranous glomerulonephritis, you will have deposition of IgG. And this pattern is very classical. It is present all along the peripheral capillary walls, not much in the mesangium. And if you look at this in hyper, you can see that these deposits are very finely granular in nature. In addition to IgG, you will get maybe some small amounts of IgA, kappa, and lambda, but C1q will always be negative. On EM, normally the IF and the light microscopy is good enough to make a diagnosis, since we must show you, therefore, what will you see on EM? On EM, again, this is the photocytopathy, which shows diffuse effacement of food processes, and then you have those classical subepithelial deposits. So this is the photomicrograph of a case of membranous glomerulonephritis of early stage. Here you have the basement membrane. This is your endothelial surface. Now, on the outer surface of the basement membrane, you see these large electron-dense deposits. These are your classical feature of membranous gene, and they are called as subepithelial deposits. Now, in between these subepithelial deposits, the basement membrane tends to grow upwards to form the spikes. So as this disease progresses, these spikes close over the deposits, incorporating them into the glomerular basement membrane. Still later, these deposits are broken down and they eventually are absorbed and disappear, leaving behind the empty holes in the basement membrane, which are then covered, leading to finally a marked thickening of the basement membrane. Here, as you can see, this is a high-bar view of the EM of the basement membrane. This is very thick. It shows these electron-dense deposits, which have now become incorporated in the substance of the basement membrane. They're not so dark green color as well. In this figure, you can see that they're getting absorbed, and the basement membrane material, it is now formed on the outer surface of these deposits as well. Here also you can see they gradually become incorporated into the basement. This is a scanning electron microscope view of the basement membrane with use of membranous GN. So you can see, like almost like chicken pox, all these deposits are seen. Some of them are open to the surface, some of them are covered, and they almost look like chicken pox. Horrible looking. Imagine what if you have this in your own body. It's not a nice thing to have. So this is a pictorial micrograph of the different stages of membranous GN. This is from Robbins. So you can see that this orange structure, this is your basement membrane. In the early stages, you have these immune complex deposits on the outer surface, which are black in color. In the second stage, they become incorporated into the basement, glomerular basement membrane, which is now much more thicker. In the third stage, they are completely incorporated and the basal membrane goes over the deposits. And in the fourth, they start getting absorbed, leaving behind only the glomerular vessels. So these are the four stages of MGN, which can be identified only on EM. How do these patients clinically present? They present as very heavy proteinuria. The degree of proteinuria is in fact much more heavier than even minimal. The difference of minimal change diseases is that this proteinuria is non-selective in nature. That is, there is loss of both albumin as well as larger globulin molecules. The response of this is, again, this disease is treated by steroid, but the response is not as good as minimal change disease. For 10 to 30% of these patients, they have some kind of a complete to partial response, but the majority of them will, in the patient's proteinuria will persist, and eventually about 40% of them will be progressed toward to chronic kidney disease over a period of 2 to 10 years. So that finishes off with your membranous glomerulonephritis. Now we come on to your fourth disease, that is your membranoproliferative. Now, we discussed last time what are the patterns of injury of inner glomerulus, and in that we had discussed that one pattern was membranoproliferative nephritis, right? So, as I explained to you, this is just a pattern of injury. This does not determine what is the final diagnosis. The final diagnosis is determined only by IMI. So, what does this pattern of injury look like? Now, as the term membranoproliferative suggests, and there is proliferation which involves the capillary walls as well as the mesangium. So as you can see in this picture, the glomerulus is quite enlarged in size. There is a lot of mesangial hypercellularity. In focal areas, there is also, let me show you. Yeah, so you have in some areas you have some degree of endocapillary proliferation, not too much, right? Then what is more important is the capillary wall. It shows modeling or double contour formation, which I will show you in the other different states. As a result of all these changes, that is increase in mesangial cellularity, in capillary proliferation, and capillary wall remodeling, the glomerulus develops, becomes enlarged in size with a very classical pattern, which is called as lobular accentuation. If you can see this image, you can see the glomerular duct has now become divided into lots of these globulins. So this globular pattern is very classical for membranoproliferative glomerulus. This is a hyper view of a glomerulus showing features of MPGN. Again, this is very large. You can see the lobules, lot of increase in mesangial matrix and cellularity. Focal, you have endocapillary proliferation and infiltration by some bone. We do the silver stain, you can see that the PS stain, you can see that the basal membrane shows two layers. You can see two dark layers here. Again, you can see two dark lines over here, and here also you can see two dark lines. So this is called as double contouring or duplication of the basal membrane. This is still better seen on silver stains. For example, here you can see the two black lines. Here you can see the two black lines, and here also you can see the two black. So these kind of double contouring is the classical GN. Now, membranoproliferative glomerulonephritis again can be primary or it can be secondary. It is the cause of nephrotic syndrome in about 5 to 10% of cases of idiopathic nephrotic syndrome in children and adults. Now, the clinical presentation may also be that of subnephrotic proteinuria. And in some cases, they can also present as a combined nephrotic nephritis. So it has a variety of clinical presentations, either as full-blown nephrotic syndrome, then it can present with subnephrotic proteinuria, it can present as a nephrotic nephritic combined. Now, depending upon the etiology, it is divided again into primary and secondary form. The primary MPGN, it has a very specific etiology, that is, it is caused by abnormalities of the alternative complement path. And this has now been given a new name, that is C3GN. Right? So nobody now calls this disease as primary MPGN anymore. If you see MPGN, it is always secondary. But if it is primary MPGN, is now synonymous with C3GN, and which is caused, which this etiology is very well known, that it is caused by abnormalities of the alternate complement path. So what are the causes of secondary MPGN? Again, there is a whole list, some of which are common to the previous condition that you already discussed. So I won't enumerate them once again. Let's concentrate more on the primary MPGN or the C3 glomerulopathy. Now, the primary MPGN or C3 glomerulopathy is divided into two types on the basis of its EM type. Therefore, to make a diagnosis of primary C3 glomerulopathy, EM is essential. So you have the two types into which it is divided are C3 glomerulonephritis and dense deposit. And the C3 glomerulonephritis is more common, accounts for 80% of cases. Dense deposit disease is more rare and accounts for about 20% of cases. But the common feature in both of these is that the serum levels of C3 are markedly reduced. So what is the pathogenesis of C3 glomerulonephritis? Pathogenesis is an abnormality of the alternative complement pathway. Now, in the alternate complement pathway, when you are taught complements in your initial lectures, you must have been told that it is in a continuously active stage at low levels of activity in circulation. This low levels of activity is caused by spontaneous hydrolysis of the thioester bonds of C3. And this is called as a takeover mechanism. As we know that C3 breaks up to form C3A and C3B, and the C3B then goes back again to further cause breakdown of C3. Okay? So now to prevent this cascade from developing, the body has its own mechanism, that is this C3B. This is inactivated by factors H and I. Then, in the cases of C3 glomerulonephritis, there is excessive activation of the alternate pathway cascade because of some genetic mutations or because of development of autoantibodies to the complement regulatory. So this will ensures that the C3 alternate complement pathway cascade keeps on going forwards and forwards, does not stop. All the C3 is consumed, resulting in low levels of C3. And lots of byproducts are formed which get deposited in the kidney, producing the C3 glomeruli. So, what is the pathogenesis of dense deposit disease? Now, this etiology is because of genetic mutations in children, which the genes that are involved are those which lead to formation of the different components of the alternate complement. In adults, the etiology of dense deposit disease is because of development of autoantibody to complement proteins, which is referred to as C3 nephritic factor or C3NEF in short. Now, this can be demonstrated in the plasma by different processes of ELISA. What is the role of C3 nephritic factor? It binds to C3b and decreases its affinity for factor H. The role of factor H is to decrease the activity of C3b. So once this the factor H activity is decreased, the C3b again remains active. It further causes breakdown of C3 into C3A and C3b, and then eventually leads to formation of C3 comvertase, which will then lead to formation of a C5b to C9 membrane attack complex, which will then lead to damage to the glomerular basement. So the alternate complement pathway cascade is activated, which then acts on the glomerular basement membrane, leading to their damage. Now, the light microscopic findings I have already discussed with you. We will just describe the EM and the IF findings. So, what on EM, on IF, what you get? You get only deposition of C3. There is no deposition of immunoglobulins, that is IgG, IgA, and IgG. And this deposit will be quite heavy, and it will be along the peripheral capillary walls. And this pattern of C3 deposition is seen in C3 glomerulonephritis. Pattern in dense deposit disease is a little different, which I will just show. A C3 glomerulonephritis on EM, what it looks like. You can see that there is a very fine granularity in the basal membrane. The basal membrane is markedly thickened, and these deposits of the alternate complement pathway breakdown products, they are deposited here. Their appearance is kind of similar to that of the basal membrane, so you have to look very carefully for it. Also on this, you can see that there is duplication of the basal membrane. So you have one layer of basal membrane here and one layer over here. And this is another figure where it shows a marked thickening of the basal membrane and deposition of these granular deposits. Now, what are the immunofluorescence and EM findings in dense deposit disease? So this is the dense deposit disease, as the word suggests. There is a deposition of a dense material in the substance of the basal membrane, which can also be seen on PS. This is a PS slide of a case of dense deposit disease at 100x magnification, which is why you can see the basal membrane so clear. On IF, you can see that again there is very strong C3 deposits, but these will be present along with peripheral dactyly wall. In addition, you get some of these globular deposits in the mesangium. These globular deposits, these are better seen in this picture. These are called as mesangial rings. So when the C3 deposition is present along with the peripheral dactyly walls as well as in the mesangial rings, then this phenomena is called as this is a feature of dense deposits. In EM also, the picture of dense deposit disease is very different from that of C3 glomerulonephritis. You have a much more electron dense. The term that we use is electron dense, right? Whatever is electron dense, it is not allowing the electron beam to pass through the EM, and all the electrons are reflected, and it will give you a darker appearance. So if you this is your woman's capsule over here, and here the basal membrane is kind of thrown into folds, and within the substance of this basal membrane, you have deposition of this dark gray sausage-like structure. The classical terminology is sausage-shaped or Chinese calligraphy-like pattern. So whenever you see this kind of sausage-shaped Chinese calligraphy-like pattern in the GBA, this is a diagnostic feature for dense deposit disease. This is a high-pan view of another peripheral capillary wall here. You can see this is the outer layer with the podocytes showing diffuse effacement. And then in the substance of the basal membrane, you have this deposition of this electron dense material, very classical for dense deposit disease. The clinical course of these patients is very poor. About most of these patients, they progress to end-stage renal disease, or at the most, they may show variable degrees of renal insufficiency. Right? This is for C3 glomerulonephritis. Dense deposit disease is even worse. Most of these patients progress inexorably to dense deposit to chronic kidney disease, and eventually they will require renal transplant. And when you do the renal transplant, the disease tends to recur very soon. Therefore, the long-term survival of these patients is very, very difficult. So it's not a good disease to have it. So that finishes off with your C3 glomerulonephritis. Now we come on to nephritic syndrome. Okay? Just as we discussed what was nephrotic syndrome, therefore what are the clinical features of nephritic syndrome? Nephritic syndrome is characterized by development of presence of hematuria, that is passage of red blood cells in urine, and these RBCs are dysmorphic in nature. And I've already explained to you last time lecture that what are dysmorphic RBCs look like in urine. So the patient has hematuria with dysmorphic RBCs. Patient has azotemia, that is rise in serum creatinine levels, with some degree of oliguria and hypertension. Some amounts of proteinuria can also be seen alongside, as well as some degree of edema. What are some of the common causes of nephritic syndrome? In children, the commonest cause of nephritic syndrome is post-streptococcal glomerulonephritis. Then the second most common cause is IgA nephropathy or CaNoF from interpura. And then you have the third common cause is hemolytic uremic syndrome. In contrast, in adults, the commonest cause of nephrotic syndrome in adults, nephritic syndrome in adults is SLE, followed by placental glomerulonephritis, infective endocarditis, and Goodpasture. So now we come on to the first, what is the light microscopic picture of acute proliferative glomerulonephritis? On light microscopy, this is characterized by a diffuse proliferation of glomerular endothelial cells. Now, whenever there is proliferation of glomerular endothelial cells, as you can see in this area, the capillary lumina cannot be identified. Now, if you look, this is in the 12 o'clock position of the glomerulus. If you go diametrically opposite at 6 o'clock, you can see that the capillary lumina is well seen, right? So you can the maximum amount of endocapillary proliferation is present from 12 o'clock to 1 o'clock in this glomerulus. In addition to that, there is some degree of essential matrix and cellularity and infiltration by leukocytes, which can be mononuclear cells or it can be polyp. This is the classical description of acute post-proliferative glomerulonephritis. And the common cause, now again, as I discussed with you last time, acute proliferative glomerulonephritis is a pattern of injury. It can be caused by a variety of conditions. It can be either caused by exogenous antigens or it can be caused as a reaction to some endogenous antigen. Now, the prototype of exogenous antigen is seen in post-streptococcal glomerulonephritis. Now, certain strains of group A beta hemolytic streptococci, these are nephritogenic in nature, that is, they cause damage to the kidneys. So these include types 12, 4, and type 1. All the nephritogenic strains of group A beta hemolytic streptococci, they have a specific N protein in their cell wall. This acts like an exotoxin. This is called a streptococcal pyrogenic exotoxin B or SPEP. Also, enzymogen precursor will also act like an exotoxin. So this is the primary antigenic determinant in most cases of post-streptococcal glomerulonephritis. Now, against this antigen, antibodies are formed to neutralize them, and these antibodies, the titer can be examined in the serum by various ELISA tests, which will help you to confirm the diagnosis. Now, other than beta hemolytic streptococcus, you also have certain other bacteria which can cause acute proliferative glomerulonephritis. These include bacteria such as pneumococci, meningococci, and staphylococci. Infections in viruses such as mumps, measles, chickenpox, hepatitis B and C, and parasites such as malaria and toxoplasmosis. All of these can lead to development of acute post-infectious glomerulonephritis. As far as the endogenous antigens are concerned, the prototype is systemic lupus erythematosus, where a large number of antibodies are formed against self-antigens, and these eventually go and deposit in the kidney, producing acute proliferative glomerulonephritis. Now, the classical clinical presentation in acute post-streptococcal glomerulonephritis is that the children, they give a history of a respiratory infection or a skin infection about 2 weeks prior to development of the renal complaints. The adults can also be affected by post-streptococcal GN, but are less common. As I described, this is an antigen antibody immune complex mediated disease where the antibodies are formed against the antigens of beta hemolytic streptococcus. Now, whether these antigen antibody complexes are formed in situ, that is during circulation, and then they come and deposit in the kidneys, or the antigen is primarily deposited in the GBM and antibodies then come and attack this antigen. This phenomenon is not very clear, but we do know that whatever it is, what is the method of deposition of the antigen in the glomerulus is not clear, but definitely the disease is caused by an antigen antibody mediated reaction. Now, once the antigen antibody complexes are deposited in the kidney, they cause activation of the classical complement pathway. Remember, in acute post-infectious GA, you will have activation of the classical complement pathway, not the alternate complement. Again, this will lead to fall in complement levels, but in this case, both C3 and C4 levels will be decreased. That is the difference. In C3GN, only C3 levels will be decreased, C4 will be normal, but in this case, you will have decrease in both C3 and C4. In addition to that, now these complements which are so utilized, they are also deposited with kidneys, and along with it, various similar complements are deposited, which can be demonstrated by IF or. Now, how does nephritic syndrome develop in these patients? The glomeruli, they show proliferation of endothelial cells and an inflammatory leukocytic MCD. This inflammatory reaction severely injures the glomerular walls, therefore increasing its permeability. This allows the blood to pass into the urine, producing the first symptom of nephritic syndrome, that is hematuria. And then, in addition, there is the proliferating endothelial cells, they lead to reduction in GFR, which then presents as oliguria, fluid retention, and azotemia. Once there is oliguria, this will stimulate the juxtaglomerular apparatus to produce renin. This will eventually lead to the development of hypertension, which is the third feature of nephritic syndrome. So thus, how the patient develops hematuria, which is damage to the glomerular capillary walls. Then, because of proliferation within the glomeruli, this leads to oliguria, fluid retention, and rise in serum creatinine levels. Then, from the oliguria will lead to hypertension, which will then lead to because of increased secretion of renin. So that's all the features of nephritic syndrome. So this is a diagrammatic view of the same. Please don't mind the spelling mistakes. I have borrowed this slide from somebody else. So first of all, there is infection by streptococcal leading to immune complex antigens. This leads to activation of complement and recruitment of leukocytes. The leukocytes will release various cytokines, which will induce inflammation. So this inflammation will lead to damage to the glomerular basal membrane and to increase permeability, leading to hematuria, proteinuria, and RBCS in the urine. The inflammation as well as the cytokines also lead to proliferation of the endothelial cells and the mesenchymal cells. These lead to blockage of the renal capillaries and decrease in GFR. In turn, leads to oliguria, sodium and water retention. This will finally lead to edema, hypertension, and bleeding. So, on light microscopy, as we've already discussed, the glomeruli are markedly enlarged in size. They are hypercellular. They show prominent endocapillary proliferation, increase in mesangial matrix and cellularity, and infiltration by polymorphs. The tubules may at times show red blood cell cast. This is another hyper view of a glomerulus in the acute post-infectious glomerulonephritis, showing you endocapillary proliferation, infiltration by a lot of polymorphs. Now, on immunofluorescence, you will get a very classical deposition of immunoglobulins, that is IgG and IgM, along with C3, along with eosinophils. So this is how the immunoglobulins are. This is basically a C3 site, but the IgG also is depositing a similar site. Here, these coarse granular deposits irregularly distributed along the peripheral capillary walls, and this pattern is called as a classical starry stripe. This is very classical for post-infectious glomerulus. On EM, you will see large electron-dense deposits. These are dark green color, which are present on the inner surface of the basal membrane. And then occasionally you will see deposits which are present on the outer surface. These are just one or two, and you have to really search for them. And they have always epithelial humps. Again, these epithelial humps are a classical feature for post-infection. So, what is the clinical cause of post-infectious glomerulonephritis? Usually this is sudden onset, occurring after a history of fever about 2 weeks prior to the development of symptoms. The patients show oliguria, rise in serum creatinine, and hypertension, along with gross hematuria. The urine sediment examination will show you an active urine sediment. The proteinuria may be in the subnephrotic range or may be severe enough to produce full-fledged nephrotic syndrome, and thus all features of nephritic syndrome will be covered. If you measure the serum complement levels, they will be low during the active phase of disease, and also the diagnosis will be confirmed if you do the serum anti-streptococcal or antibody titers, which will be found in the end. The prognosis of these children is very good. You treat them with antibiotics and with adequate fluids, etc. And usually they recover completely within 3 months. If they don't, then about 15 to 50% of these, however, may not recover completely. They have always atypical post-infectious GN. These will show a gradual progression of disease, until they go on to develop MCD. Otherwise, in most conditions, the prognosis of these patients is very good. So, this comes to the end of my lecture. This is a vegetable vendor in Rajasthan, and she has all her vegetables arranged around her. Next time we'll have my third lecture, and I'll just see whatever, if you have any questions so that I can answer them. Let me just see. Okay. Please show the absorption droplets in the tubules and minimal change disease. Okay, I'll just go back to the first one of the first slides. So if you can see now that it's actually a little difficult because on PS, these protein reabsorption granules, they are a little bit pink in color. So if you look carefully, this is the proximal convoluted tubule. There's a brush border over here, and you have these small pink droplets over here. Again, you can see in this tubule as well, there are fine pink droplets. These are your protein reabsorption granules. Once you see your slides under the microscope, I think you'll have a better view of this. So that is a very, very fine finding, and nothing difficult to show. Okay. Any other questions? Let me check. In minimal change disease, what is the IF change? So that is a question by Dr. Vishwa Rakesh. Okay, so this was what I showed you on in minimal change disease. IF is completely negative. Okay, so this much amount of green stain you will see because all your antibodies, they are tagged with FITC. Okay, but you can see that there are no granules, no granular deposits, and whenever the IF is positive, it fluoresces. But in this case, it is a dull green color. There is no fluorescence. So IF is completely negative in immunofluorescence, in minimal change disease. Okay, we have another question. In FSGS, what happens to the glomerular basement membranes? In FSGS, what happens to the So basically, the health of the glomerulus is depends on of the glomerular basement membrane depends on two things. One is the structure of the glomerular basement membrane as well as the arrangement of the podocytes on their surface. Now in FSGS, the structure of the glomerular basement membrane this remains unremarkable. There is no change. But the podocytes which are present on the surface, they become completely effaced and they no longer possess the capability of holding back any of the proteins. So in FSGS, the primary change is in the podocytes, not in the glomerular basement membranes, and therefore this leads to a leakage of proteins into the uterus. I hope I've answered your question. Okay, so that I think that is any more. That's the end of the questions. I hope you all were able to understand. If you have any more questions, you can always please convey your questions to your tutorial in charge, and I will request them to please convey to send all your questions to me, and I will then reply back. Thank you so much, all of you, for your patient hearing and for your interest. Good evening.